So this morning it's my pleasure to introduce Dr. Nathan White to speak for us at Medical Grand Rounds this morning. Dr. White did his undergraduate training at the University of Michigan before completing medical school at Wayne State University. He then completed his emergency medicine residency training at the University of Cincinnati and then underwent a critical illness and injury translational science research fellowship at Virginia Commonwealth University. We were fortunate to have Dr. White join us here at the UW in the Department of Medicine in 2010. He's now an assistant professor of emergency medicine, but also holds adjunct positions as assistant professor in the Department of Bioengineering and Department of Mechanical Engineering. He has been awarded numerous honors and research awards, including multiple Young Investigator Awards from the American Heart Association. He serves as a member of the Harborview Medical Center Hemostasis Committee and is a member of the formerly Puget Sound Blood Center Research Institute, but his title page reminds me that it's probably now the Bloodworks Northwest Research Institute. Dr. White has published extensively on the topic of hemostasis in the setting of traumatic injuries with 29 peer-reviewed journal articles in this field. His research has included novel mechanisms for achieving hemostasis in acute hemorrhage and the treatment of hemorrhagic shock. And as far as I can tell, he doesn't plan on slowing down because he's currently the principal investigator on multiple clinical studies involving hemostasis in the setting of combat trauma. Dr. White's presentation this morning is entitled Bioengineered Solutions for Severe Bleeding Management. So please join me in welcoming Dr. White.
Thank you very much for the wonderful introduction, Andrew. Nicely done. And thank you to Dr. Bremner and others from the Department of Medicine for the unique opportunity to be able to present work that I'm passionate about, which is bleeding. It probably makes me a little bit of a weird guy, but that's okay. And today I'm going to get even a little more weird on everyone in that I'm not going to talk about typical bleeding in terms of things like clotting cascades and factor concentrations and things like this. We're going to take a little different spin, and we're going to talk a little bit more about the physics of bleeding, understanding clot formation from a material science perspective, and how we can use that understanding to then find novel ways to engineer clots to achieve the outcomes that we want in our bleeding patients. And the focus today is going to be on trauma, which is my specific focus area. But I think the application is very widespread to all situations of bleeding. So let's get started. Here's my disclosures. The only thing I wanted to point out is that I am a co-founder of Stasis Medical Corp, which is we're commercializing some of the platelet diagnostic technology that I'm going to be referring to in the presentation today. So I am a little biased in that regard. So let's talk about trauma. So trauma, #1 cause of death for young people between the ages of 1 and about 44, 45. About 30% of all age-adjusted life years lost is due to trauma. That's more than cancer and heart disease combined, primarily because trauma affects young people who have lots of living left to do. Over 40 million ER visits, which I care about, 2 million hospital admissions, almost $500 billion of economic burden from traumatic injury, 200,000 people lose their lives every year to trauma. And to add insult to injury, it's preferentially affects people in low and middle income countries. So if you take the young, healthy adults who are the primary breadwinners of families in low and middle income countries, trauma is the primary disease process that takes these people away from society, which adds extra burden to an already burdensome situation. Bleeding from trauma accounts for about 30% of mortality. It's the leading preventable cause of mortality after injury. And bleeding is quite unique because it not only kills a lot of people, but it kills very quickly. So if you're injured, severely injured, and you die from a traumatic injury, if you're on the field of combat, 90% of those people will never make it to any sort of medical facility. If you're in a rural area, 80% of those people will never make it to a medical facility. And even in urban areas like Seattle, if you're injured and you're bleeding severely, and you eventually die from trauma, the majority of those people won't even make it to Harborview. So if we combine the speed at which bleeding kills after injury, and we combine that with other things that are happening these days, like the aging of our population, many fancy new direct oral anticoagulant agents, which have no antidotes for, a brand new antiplatelet agent coming out about every week or so. This is what I call the perfect storm for bleeding. This is the end of days for me as a clotter. So I see this and I get really scared. So bleeding is only going to get worse, which means we all have to get better at managing bleeding patients. So how do we do that now? Well, we have trauma systems of care. Here's us right in the middle. Here's the rest of the Pacific Northwest. We do things like massively transfuse trauma patients with lots of blood products, trying to keep up with bleeding, eventually stopping bleeding, hopefully. We have dedicated trauma surgeons who are awake in the hospital 24/7, who dedicate their lives to stopping bleeding and rescuing these injured patients. We have some fancy-ish technology to help us understand clot formation that's now being used to help understand the physics of clot formation and to tell us what's wrong in these situations so that we can fix it more specifically. We have some fancy new things like factor concentrates that we're now using to actually replace and supplement the coagulation cascade. So we can now become a bit more specific about how we're treating these patients. But what I want to talk about today is the next generation. What do we do if we don't have the ability to use factor concentrates? What do we do if we don't have trauma surgeons available, which is the majority of bleeding situations? Thankfully, I think we're living at a great time to find solutions and novel solutions, especially in the area of biotechnology and engineered solutions. Moore's law keeps going up. Technology keeps getting faster, which means that we are now enabled to think rationally, and if we understand clotting and bleeding from the right perspectives, then the solutions are obvious. I'm going to give you a couple examples of work that I'm working on with some collaborators to find some of these novel engineered solutions. But first, let's talk about the two major types of traumatic bleeding. There's the high pressure, big holes, arterial bleeding, and there's microvascular bleeding. So this is coagulopathic bleeding. First, let's take a quick look at high pressure bleeding. High pressure bleeding, I like to say when you encounter high pressure bleeding, you have to pay attention to the 3 C's. That's containment, compression, which then enables coagulation. So blood is no good if it's on the floor, right? It needs to stay inside the body, even if it's outside of the vessel. You do everything you can to keep the blood inside the vessel. The next priority is to reduce blood flow within that bleeding vessel, which is going to have the highest impact on actually reducing blood loss. If you can make this happen most of the time in a high pressure bleeding situation early on, the blood's coagulation response is adequate to stop the bleeding. Here's some examples. So this is from a research laboratory. Here's an example of high pressure bleeding from a femoral artery. This is in a large animal model, and it's not working. Okay, here we go. First bleeding video. Maybe more to come. So this is a femoral arteriotomy. So this is what I mean when I say high pressure bleeding. So this model, untreated, has a mortality of about 30 minutes. This is what you see typically in combat injury, in the junctions, in the axilla, in the groins where body armor doesn't cover. This is what our soldiers are dying from on the battlefield when it comes to bleeding. Here's an example of containing this bleeding. This is a new hemostatic clamp that we tested, which all it does is it clamps the skin over the wound very quickly. Clamp, one motion. And now what you have is an uncontained bleeding source, which is now contained almost immediately. But of course, that's not the final solution, because when we look underneath this clamp, this is the bleeding femoral artery right here. This is the swirling hematoma 5 minutes after onset of bleeding and clamping. You can see the jet of blood coming out of the femoral artery swirling around. This is the beginning of hemostasis right here. This is how it all starts. And if you look at this over time, what you see is that gradually the area of bleeding of liquid turns to solid. It clots. This hematoma clots, and it starts to contain the bleeding. It caps that bleeding femoral artery. We were actually able to use ultrasound elastography to measure the stiffness of this clot as it formed over time. What we found is that at the most distal part of the hematoma, that the clot forms first, works its way back towards the bleeding source, which is at the white arrow here. But what we also found was that it never totally clots the vessel. So in high pressure arterial bleeding, you have to somehow reduce the blood flow in the vessel to totally clot this hematoma. There will always be a small area of high pressure circulating blood outside of the vessel in this situation. Which leads to a problem, right? So here's the hemostatic bandage. Can anyone find it? It's right there. It's this little clump right here with this gigantic hematoma that's now accumulated because you're not able to clot the entire space. The high pressure builds up, it starts to dissect through the fascia, and you continue to have blood loss. It's internal blood loss now, and it's contained, but you continue to have blood loss over time in these situations. This is what I call the water under the dam phenomenon. You have a dam, high pressure starts to work through the cracks to escape over time. And this is what you get. If you're unable to fill that space, this is breakthrough bleeding from a hemostatic bandage right here over time. It's not very subtle, to say the least. So, in understanding this process, we thought, well, how can we better improve the distribution of a hemostatic agent inside of these large wounds in the face of high pressure arterial bleeding? So we teamed up with Christian Kastrup and his lab at the University of British Columbia to come up with a novel solution. And this involves self-propelling microparticles. So the concept here is to use calcium carbonate microparticles, dope them with thrombin, and then when calcium carbonate comes in contact with a weak acid, in this case we use tranexamic acid, what happens is you have production of CO2. So because of the size of the calcium particles, when they produce CO2, they actually are able to self-propel themselves through blood against the flow of blood, carrying their cargo, which is thrombin, which we hypothesize would improve clot formation and help to induce clot formation, fill those cracks that the wound is bleeding from that a bandage can't cover. They activate and shoot around and fill the space. Here's an example of a control and an active calcium carbonate self-propelling microparticles on the right. It's pretty dramatic. So what we did is we took this and we incorporated it into a hemostatic bandage. So we took a bandage, we coated it with the calcium carbonate microparticles, we put a layer of dried tranexamic acid, so a 2-layered bandage. We stuffed it into the same femoral artery wound, and this is what we saw. We like to call it magic bubbles. Here we go. So we've already stuffed the bandage into the wound, and now what you see is the bubbles coming out, right? So this is active inside the wound. It's propelling those microparticles throughout the wound, helping to induce hemostasis faster. And what we really saw here was that it maintained hemostasis much better, and breakthrough bleeding was much less. The bandage was actually able to reseal itself over and over again. As more bleeding came up, it would activate and reseal itself over and over again. There it is. Point to it. When we did a study in our large animal model, femoral artery bleeding model, 100% survival with the propelled thrombin gauze. This is the standard of care right here. This is a hemostatic kaolin gauze. This is a non-propelled thrombin gauze. So it has the same calcium with thrombin, but it's not propelled. So it's not activated by unprotonated tranexamic acid. So it's really, the effect, the survival benefit was really from the propelling action. It's not from the thrombin that we added to the gauze. And this was due primarily, we think, to a much decreased rate of hemorrhage of blood loss from that wound. So that's an example of how if we can look into wounds and we can understand the process of high pressure bleeding, how we can come up again with some novel solutions. So let's turn our attention now from high pressure bleeding to the leaky bucket, which is coagulopathic bleeding. This is a situation where there's really no large bleeding vessel that needs to be surgically controlled, but the patient is oozing and bleeding from every place. So we've all been in this situation. It's a very dire situation. And in this case, what we really need to look at first is the blood clot itself. So this is the primary determinant of this type of bleeding. How this clot comes together is really what counts when it comes to microvascular bleeding. So let's take a closer look inside the clot. And I'm going to focus on the two primary components of the hemostatic clot, which are the fibrin fibers and the platelet aggregates. Of course, there's red blood cells, lots of proteins in here, but I'm going to focus on these two as the primary mechanical determinants of hemostasis in this situation. Fibrinogen and fibrin, of course. Fibrinogen is in all of us in our circulation. Thrombin activates it. It self-polymerizes first into fibrin protofibrils and then into branched fibrin networks. Here's an example of fibrin at multiple length scales. You see it's highly ordered at multiple scales, and this is no mistake. What this allows is the fibrin clot itself to mechanically adjust itself so that it can control hemorrhage in wounds. And this happens at many different levels. This happens at the whole clot level. When you stretch the clot, the network reorients, squeezes water out, gets denser, gets stiffer. It happens at the fiber level, where each protofibril, twisted fiber, stretches in a particular way. It even happens at the molecular level. So each fibrin molecule unfolds in a certain way to contribute to the overall mechanical performance of the clot. What this enables is something that we call nonlinear behavior, or non-Newtonian behavior, in which you apply a strain, a constant and increasing strain to a fibrin clot. What you get is a nonlinear response, in that at low strains it's quite pliable. At higher strains it becomes very stiff. And this makes sense when you think about a clot on a wound, especially on an artery. With every heartbeat, that clot is being stretched and pulled as the vessel expands and contracts. This is our body's way of compensating for that repeated deformation. The other component of clots that we need to pay attention to, of course, is platelets. Platelets aren't just little non-nucleated, discoid, little discs that float around and stick to stuff. They're actually quite active. They have some very interesting behavior which enables hemostasis. And the first is shear activation. So platelets spontaneously activate to shear. They get really sticky really fast. Here's an example of platelets in whole blood with an increasing shear rate over a von Willebrand covered surface. Oh, not that one. And you're ramping up the shear as this video goes on, and you see what happens to these platelets. These are fluorescently labeled platelets. And the shear is going up and up and up, and you see these huge aggregates start to spontaneously take place. This is exactly what happens in those high shear areas. You saw that jet of blood coming out of that femoral artery. It's exactly what happens. Those high shear platelets turn on immediately and start to clump during primary hemostasis. Here's another example of a ferric chloride injury model. This is in a mouse carotid artery. We have a red blood cell clump that is formed from the ferric chloride here in the vessel. And you see what platelets do when they encounter this obstruction. Immediately stick, immediately adhere. And the result are these platelet-rich plugs that appear within seconds after any sort of high shear obstruction to their flow. So platelets not only stick, but they also activate and contract. You can think of them as the little muscles of the clot. And they achieve this by contracting their marginal band, which is a complex of contractile fibers, actin, myosin, within each platelet. Here's an example of a platelet activating. This is a single platelet on your left. This is stained for the marginal band on the right. And they're going to activate this platelet, and I'll tell you when they activate, and then we'll see what happens. So here's your platelet on the left. Here's its marginal band here. And they'll hit it with an activator here when the screen flashes. There, now it's activated. Now see what happens. The band twists on itself. Little arms come out, and it starts looking for fibrin to pull on. There's a few billion of these in each one of us right now, which is a little scary. It's got one little arm left looking for some fibrin to pull on, right? So they're very active. So what does this do? So if you put together the nonlinear behavior of the fibrin network itself, and you add a contractile element, which is the platelets within the clot, what you have is initially a soft clot that spontaneously adjusts its tension to its environment. So it's actually a natural bioengineered material, a smart material, that's designed to stop bleeding by balancing platelet contractile forces and the structure of the clot. And if you think of it, it's no different than when we build buildings. When we make poured concrete, we use these tension rods, right? You pull the tension rod, you pour the concrete, you snap the clips, and the rod compresses that concrete pylon, right? What does that do? That adds resistance to compression, reinforces it, increases the overall stiffness by compressing. It's the exact same thing that our platelets do to our blood clots. So what happens during trauma-induced coagulopathy? Well, it's a combination of injury and shock. Injury produces thrombin from tissue factor release from injured tissues. As you have blood loss, shock ensues, you get consumption of factors, you get anticoagulation from protein C activation, you get very early platelet dysfunction, so you start to lose that ability for the clot to modulate itself, and you get hyperfibrinolysis. So you get TPA release, plasmin generation, and that network structure starts to get cleaved down, cut down very rapidly. So the resulting functional problem in clot formation during trauma-induced coagulopathy is primarily a decrease in clot strength, which is primarily due to platelet dysfunction initially. In addition, you have hyperfibrinolysis. So these are the two main components that we see very early on in the emergency department after traumatic injury. So in realizing this, we thought, well, maybe we can turn this and use it to our advantage. Maybe if we look at platelets specifically, and specifically if we look at the way platelets contract after activation under these high shear conditions, maybe we can use that as a way to identify coagulopathy very early on. So I partnered with Nate Snydecki in the Department of Mechanical Engineering in the Cell Biomechanics Lab to look specifically at the possibility of doing that. What we came up with is a new microfluidic card that is decorated with these small obstructions. So we have a block followed by a flexible micropost sensor. The thought here is to have the platelets encounter the block, activate by shear, aggregate, and contract this post. Since we know the dimensions of the post and the material, we can identify the Young's modulus and we can calculate the actual force it takes to move this post. Here's an example in whole blood of shear activated platelet microaggregates deflecting the post back towards the block. Here's a before and after picture here. So what this enables, we use optical techniques to track the position of this post. So what this enables us to do is very quickly draw a force curve in nanonewtons of these platelet microclones. So we thought, well, this is really cool, right? Cool pictures, right? But is it useful for bleeding situations in trauma patients? So we took it to Harborview, took it to the lab in Harborview. This is a preliminary result of a study that's now fully enrolled with over 120 patients. What we found was that the first platelet force, these are platelet force curves, the first measurement in the emergency department, on arrival to the emergency department, we could actually differentiate those patients who were a full trauma activation versus a modified trauma activation versus healthy controls. In addition, we were able to differentiate those patients who would go on to require any blood product transfusion in the first 24 hours versus those trauma patients who did not. Their forces, those who got transfused had initially decreased platelet microforce. What we found was that our odds ratio was significant. What we found was that the odds of receiving a transfusion was decreased by 3% for every 1 nanonewton increase in platelet microforce, measured on arrival to the emergency department. So like I said, this study is fully enrolled and the full data analysis is underway right now. We're actually getting ready for publication. So it looks like paying attention to these microforces and these platelet forces might actually be helpful for quickly identifying coagulopathic trauma patients. Not only that, it's super cool, and I think it's a neat way and a new way to look at platelets in real time. Here's an example of calcium fluorescence in these platelets. You can see there's very strong activation, and there's no agonists here. This is just shear. So in addition to a diagnostic, we feel like it might be an important research tool to understand platelets in these conditions. Now, the last and final problem that I'm going to talk about is the problem of clot durability. And this might be the biggest problem that we encounter in coagulopathic trauma patients. This is a result of a decrease in clot durability from enzymatic fibrinolysis. So shock induces TPA release from the endothelium, plasmin is generated, Pi1 goes crazy or gets disinhibited, and clots are rapidly degraded over time, so that any clot that you might form in a wound doesn't last very long. Now, we treat this currently with an enzymatic inhibitor called tranexamic acid, which blocks the action of plasmin on fibrin. But since we now understand the importance of fibrin clot structure and how it comes together, maybe there's another way that we can approach clot durability after injury. And what we looked at specifically was the action of factor 13. So what factor 13 does is it cross-links fibrin protofibrils. It's a transglutaminase. And what that does is it drastically increases the strain stiffening behavior of clots when you apply dynamic stresses to them. And we thought, maybe this might be another way to rescue clots after injury. What cross-linking does is it allows durability over time, because now in a cross-link clot, you don't have this buckling and this hysteresis, the slippage between protofibrils from repeated deformation over time. If you can cross-link the clot adequately, you can maintain its durability and keep its functional relevance over a longer period of time. So, in order to do this, I teamed up with Susie Pun, who's a extremely smart professor of bioengineering here at UW, her graduate student, very talented, Leslie Chan, who's at MIT right now, to come up with a synthetic strategy for actually enhancing clots by direct cross-linking. What we came up with is a new hemostatic polymer that we call polystat, so for polymer hemostat. What it is, it's a hydroxymethacrylate backbone polymer, which is a very biocompatible. It's a component of contact lenses that I have in right now, so I can see everybody. And what we did is we took this polymer backbone and we attached these small fibrin-binding peptides, multivalent, so we had about 16 peptides on each polymer. This is a peptide that we found in the literature that was designed for imaging clots in vivo with MRI technology. It only binds to fibrin, it does not bind to fibrinogen. So only after the clot is polymerized does this polymer form. Our hypothesis was that if we attached these multivalent peptides to the polymer backbone, it could perform as a cross-linker. It could cross-link adjacent protofibrils together and build polymer bridges within the clot that would then be resistant to fibrinolysis and increase clot strength and durability over time. Here's an example of our specificity. Here we have our scrambled peptide. This is our non-functional. This is our active polymer peptide here, and this is our control. We can see that very specifically, the active polystat targets and incorporates itself into fibrin fibers, very specifically. Not only does it get into the fibrin clot, but it drastically changes clot structure. You can see here's our control, here's our scrambled non-functional peptide, here's active polystat, and this is the comparison to actually human factor 13A cross-linking. You can see a very drastic change with multiple more linkages between these fibrin fibers inside the clot. What this does is it closes the pore structure in the clot down, which is one of the limiting factors for plasminogen and plasmin to actually get in and bust a clot. It needs to get into the clot. And if you close these pores down, it limits that access. So we have significantly smaller pore sizes. At the same time, it increased the functionality of the clot as far as increasing its stiffness across multiple fibrinogen concentrations. So it's this two-hit sort of benefit to decrease fibrinolysis and at the same time enhance clot strength. Let's see if this is going to work. Oh, it's working. Good. So here we have an example of the effect on fibrinolysis. This is a confocal, and a little bit of plasmin was put right up in this right corner here. And we measured the rate of the clot dissolution front. You can see how quickly, this is sped up a little bit, but they're the same speed. You can see how quickly and how efficiently plasmin cuts fiber. But in the presence of polystat, you can see that that is significantly delayed. We were able to delay it by about 3 times. It took about 3 times longer to lyse these clots versus control clots. And if that's not enough scientific rigor for you all, here's the ultimate in the scientific method. This is a video that Leslie took when she was trying to wash out this polystat clot after taking those confocal images. So this was a control clot here, control clot here. You can see they're already washed out. She took it to the sink, tried to wash it out under the sink, and this is what happened. So at first, and if at first you don't succeed, what do? Turn it up, right? So that's how dense polystat has modified that fibrin structure. It's closed the pore, that's a watertight clot right there, right? And she was mad at us because the first time she did this, it sprayed up all over her shirt and got her all wet. And then we said, hurry up, take a video. Do it again. Like any good PI would do. So that's great. It works in the sink, right? That's awesome. But does it actually stop bleeding? So we took this to our rat femoral artery hemorrhage model that we used, which is a sort of a 3-phase model. We have initial catheter hemorrhage to lower the blood pressure so the rat doesn't bleed out. We open up a 3-millimeter longitudinal incision in the femoral artery here. At that point, we open the artery. We inject polystat here at time 0. We do nothing, don't touch it, don't do anything for 15 minutes and just let it sit there. At 15 minutes, we still do not touch anything, no bandages, no nothing on the clot or on the wound, and we start to infuse saline to bring the mean arterial pressure back up. To see, first of all, if polystat could reduce this bleeding here, and then if the clot that was formed could withstand the pressure of resuscitation. What we found, 100% survival to 75 minutes in our polystat group compared to the other relevant control groups here. And again, we think this is a result of a significantly lower rate of bleeding. So I'm going to wrap up. These are just a few examples of working together in scientific teams, which of course is not only the cool thing to do, but is really the way to go for research in the 21st century, right? This is team science. There's no way I could have engineered any of this stuff myself, so I needed to find smarter people than me to do this. This is a great collaboration between the UW College of Engineering, UW School of Medicine, Department of Medicine, Division of Emergency Medicine, and it's really a lot of fun. So if you're all thinking about doing research like this, I would encourage you all, build your team early. Get a good team. Strive to be the dumbest person on your team if you can, which helps. And then you can really start to tackle important problems from really unique angles. I'd just like to acknowledge my collaborators, of course, Dr. Stern, who's a tremendous advocate as our division chief in emergency medicine, my colleagues in the Emergency Medicine Research Lab, colleagues at the formerly Puget Sound Blood Center, I need to update that, now BloodWorks Northwest, colleagues at VCU and at the University of Michigan. Well, thanks for your attention. I'll take any questions.